It's 2 o'clock and we're going to get started. Today's presentation is about normal brain changes with aging and how to reduce the fear of dementia with Dr. Catherine Madison. My name is Lola Rain and I am your host today. And I want to give a special thanks and shout out to Sequoia Living and Senior Services of Northern California. Now, Sequoia Living is a nonprofit that serves the Bay Area, and Senior Services of Northern California is the philanthropic foundation that supports many of the services and programs that Sequoia Living has, such as the San Francisco Senior Centers. There's two, one at Aquatic Park and one downtown. There's a program, a volunteer program called AARP Experience Corps Bay Area. And that's where older adults volunteer to read with children. And the focus there is to eliminate reading issues, because those who do not learn to read before the third grade, before the end of the third grade, have a lower chance of actually graduating high school. And so we have a whole group of volunteers, a couple hundred, that go out to schools as well as do it through Zoom, like today's presentation, but they read it to students. And then we have a resident services program and an intergenerational program. Now, I'm going to share a little bit more with about Sequoia Living before we meet our presenter today. And I wanted to do a little bit of housekeeping. So let's take a look at the chat box down at the bottom of your screen. Most people's at the bottom of your screen if you're on a PC. It could be in a different location on a Mac. Sometimes you have to mouse over the bottom of your screen in order to see the chat box. And that's where we're going to be utilizing to do Q&A today. So you'll be able to make comments throughout the whole presentation, ask questions, and then we've saved some time at the end to have Dr. Madison answer questions. What I'd like you to do is go ahead and chat in the chat box your current location. So if you're in San Francisco, type in San Francisco. If you're in Portola Valley, type in Portola Valley. So go ahead and use the chat box there. And then while you're doing that, I'll go ahead and let you know just a little bit more about Sequoia Living. And we've been in the Bay Area since 1958, and we have several communities. The three that you see in front of you here, we have Town Park Towers in San Jose on the left, Eastern Park Apartments and Western Park Apartments, both in San Francisco. And those offer affordable housing to people who meet a certain income level. The other communities that we offer, we have our flagship community. This was the first one to open 60 years ago in Portola Valley, and it's 42 acres just west of Stanford University. And it backs up, or I guess I should say Windy Hill Open Preserve backs up to the Sequoia's Portola Valley. Beautiful campus, all one-story living. We also have the Sequoia's San Francisco, and this is just near the gates of Japantown and right on Geary Street in San Francisco. And it is a beautiful 26-story building with a lovely multi-story atrium where lots of parties and social events happen. And this is a wonderful community in San Francisco that's been around since the 1960s. We also have the Tamalpais Marin that's in Greenbrae, and it's right there at the base of Mount Tam. And it's got beautiful mountain views as well as bay views. You can see straight out the bay when you're standing there at the community, and a lovely swimming pool as well. Then our newest community, this is Viamonte at Walnut Creek in the East Bay. And this lovely community opened in December of 2020. So it's been open for almost a year now. Right, I want to go ahead and take a look at where some people are saying they're located at. And we see San Francisco. We have Oakland, Studio City, Huntington Woods. Is that Michigan? Oh, Lake Spur, Walnut Creek, Portola Valley, Richmond, San Rafael. Well, thank you everybody for joining us today. I know I know today's topic can be a little bit of stressful thinking about, but I'm glad that you're joining us so that you can hear what Dr. Madison has to say so that we can all learn about how our brain changes as we grow older. So with that, let me get to introducing Dr. Madison. Now, Dr. Madison is a board certified neurologist who specializes in dementia care, and she's a Bay Area native. And she served 8 years in the Air Force before coming back to the Bay Area and caring for her mother who was living with Alzheimer's disease. She founded the Ray Dolby Brain Health Center in 2012, thanks to the Dolby Family Foundation. And currently, Dr. Madison works with Seniors at Home, which is a Jewish family and children services organization. So Dr. Madison, you can go ahead and turn on your camera and your mic, and welcome.
Hi there.
I'm really excited about your presentation today. I feel very privileged and fortunate to be able to have spent some time with you over the last couple of weeks learning more about this topic. And we're going to start by asking the audience to answer a question. So let me queue up this poll, and so that everybody who's on today's Zoom call can see. The poll number one, the question is, do you feel your everyday memory lapses are increasing as you age? So we'll give people a few minutes to be able to fill this out, and then I will show you the results. So it looks like we have about 70% of the participants on today's call have filled out this so far. Let's see if we can get to 100%. All right, we're at 80%, 84%. Okay, I'm gonna do a 10-second countdown so everybody get your poll answer in. Is it yes or is it no? Okay, I'm gonna go ahead and share the results there. Can you see that, Dr. Madison?
I sure can.
Okay, wonderful. So 80% of people who answered this question said yes. So what are your thoughts around that?
Well, why don't we go to our next slide?
Yes, let's do that.
So it actually turns out that older adults experience more word finding failures is what they're determined. These tip of the tongue experiences can't come up with the name of a particular actor in a movie, the author of a book. And as we age, those events do indeed happen more frequently. Unfortunately, there's also a little bit of a parallel age-related decline in retrieving the spelling of familiar words. And this has to do really with retrieving the sounds that make up a word, because when you are experiencing this, you know what the word is, you understand what it is you want to say and in what context you want to use it, but you cannot put together the particular sounds that make up that word. So unfortunately, yeah, you're right. You are having more trouble. It's usually finding and generating words, though, not exactly memory. We associate it with memory, though. Can we move on to the next slide?
Yes.
So what I'm hoping we can all talk about and learn today is what are some of the normal brain changes that happen with aging, and what is dementia or neurodegenerative illness, and how do we communicate with people who have impairment, and how do we start conversations about future planning for ourselves? Because I firmly believe that by planning our future and including this as a variable, we actually reduce our fears. Next slide. So let's start with understanding that dementia is not always a specific diagnosis. Dementia means that someone has a decline or a change in their thinking that can relate to memory, it can be behavior, language, or even some of your complex, computational abilities. And the decline in those abilities is significant enough that it affects your ability to function normally, independently in your day-to-day life. That is the definition of a dementia. And we have over 6 million Americans today living with Alzheimer's disease. So it's pretty darn common. You might notice way down in the corner of that slide too, that there was a 16% increased death in 2020 related to COVID and the severe isolation that seniors experienced. Next slide. So we'll talk now about some of the main types of dementia, because there are actually many more than I have on your screen there. Alzheimer's is the most common, over 60%. And with an Alzheimer's dementia, we typically associate that with the memory loss, although there can be changes in behavior and language and other things going with that. And unfortunately, I need to share with all of you that the cause of a dementia is not always just one specific thing. There are changes going on in the brain. We call those pathological changes, abnormal proteins that accumulate inside or between nerve cells. And the types of pathology in the brain can actually be mixed, making the diagnosis even more complicated. So with an Alzheimer's disease individual, their brain may also have some changes related to vascular damage, related to either strokes or miniature small strokes, areas of what we call ischemia, that they don't notice, but cumulatively cause enough damage that it meets the definition of a dementia. Then there are Lewy body disorders, and this relates to the abnormal proteins in the brain. And in these types of a dementia, as in Parkinson's disease, memory is usually pretty well spared, but they have a lot of visual spatial difficulties. They may have trouble seeing things, and they have motor symptoms, as you might be familiar with Parkinson's. There can be slowed movement, there can be tremor, there are falls. And those are some of the hallmarks of these kinds of dementia. And then there are the frontotemporal lobar dementias, which tend to involve language and behavior and can be the most difficult. Next slide, please.
Can I ask you, Dr. Madison, vascular dementia, this is something that my father has been diagnosed with, and he was told it was from multiple concussions he's had over the years, having head injury. Is that a possibility with vascular dementia, or does it naturally occur?
So you can have a head injury and end up with bleeding in the brain, and that would be considered a vascular injury. You can also, though, have something which is called chronic traumatic encephalopathy, which is associated with boxers. So there are different things that can be going on. Most likely, Lola, they were able to see areas of abnormality on the brain suggesting that there had been blockage of a blood vessel, or that combined with the damage he might have gotten from an injury to kind of lump it all together as a vascular dementia.
Interesting. Thank you for sharing that.
Now, then we have the quote unquote reversible dementias. And certainly for all of us, if we don't get enough sleep, if we've got too much of a medication or a drug in our system, if we have an illness, an infection, our brain is not thinking as clearly as it should. There are other conditions, hormonal imbalances, vitamin deficiencies that a doctor specifically looks for, because if those are treated and they are indeed the cause of a cognitive impairment, it can actually get better. And then there is depression. And depression is somewhat unique here in that it can be an early symptom when someone is coming down with a dementia, or it can appear later as a sign in the illness as an individual becomes more impaired. So let's move on to our next slide.
We have another poll for the audience. So let me cue this up for you. Let's see. Number 2. Now we have a question before we go into this poll. We have a question from Anne. What vitamin deficiencies could or would cause dementia?
The biggest one that we're always looking for is B12. So, but several of the B vitamins. And we have more trouble absorbing B12 with aging, so it should be checked for.
So the poll question that you see in front of you right now, do you get a good night sleep at least 5 nights a week? I must say that sleeping is something that I've struggled with over the years. So I actually set it as a goal. I wanted to improve my sleep because at 49 years old, I was having a lot of difficulty functioning during the day with some fog and extreme tiredness. And so I set it as a goal, and I was forgetting a lot of things. I set it as a goal to sleep better. And guess what? Because I put it as a goal, I actually now sleep at least 5 nights a week. So let's go ahead and give you just a couple more seconds to answer your poll question, and then I will share the answers with the audience.
And Lola, do you feel your thinking cleared up as you got more sleep?
I definitely stopped saying to myself all the time, oh my gosh, I forgot to pick that up. I forgot to do this. I forgot to do that. And maybe it was also a reduction in stress, but I think sleep just has an overall, it improves your life if you have better sleep. So do you see the results in front of you?
I do. And so that's actually pretty darn good. So we've got 62% of people who say they are getting a good night's sleep at least 5 days out of the week. And it becomes it becomes more difficult to get a good night's sleep as we age, because unfortunately, with aging, our sleep becomes more fragmented and shallow. So as Lola was talking about setting a goal, along with really paying attention to sleep, it is all the more important. On the next slide here, I just have a couple points there. So the encoding of information that goes on in our brain during the day is actually consolidated in our sleep at night. Tests have been done on young people, and you show that if they pull all-nighters, they actually cannot learn as well. So sleep is essential for all of us, but even more important for us as we age. In addition to what I'm talking about here with memory, research is supporting that sleep is actively draining toxins from the brain that might accumulate during the daytime. So it's very important.
Wow. It is amazing what happens inside of our brains at night that we just don't know about. I want to remind the audience that you can ask questions in the chat box at any time, and we'll try to make sure that they get answered real time, or else we'll save questions to the end if we don't get your question answered.
Okay, and on our next slide, let's start a conversation about screening. And I'd like everybody in the audience to try to understand that doctors are coming from a background of decades here of the mindset, why diagnose early a disease that is incurable? And they're really not paying attention to what we've learned from other chronic illnesses like heart disease, HIV, and some cancers, and that in making lifestyle changes, you can actually affect the course of these illnesses. In addition, between 2002 and 2012, there was a 99.6 failure rate in Alzheimer's medication. So it's crucial that people can get diagnosed early in the course of a neurodegenerative illness or dementia, so we can get them involved in clinical trials and come up with better treatments. And my last point there is that seniors are at high risk for financial abuse. And as we talk more about what changes can go on in your brain, you'll understand why you should get tested. Next slide.
Can I ask a couple of questions that popped up from the audience?
Sure.
So a couple of questions were back about the sleep. So what are important ways to get better sleep? And then also if they're taking medication, is that considered, if they're taking melatonin or something as a sleep aid, is that considered a good night's sleep?
Okay, so first off, there's a whole lot of things you can do to try and get better sleep. I actually describe strategies for good sleep hygiene. And I will say to people that it's just like good oral hygiene. We take care of our teeth. We need to take care of our sleep. It's having a regular schedule or habits around sleep. It's avoiding alcohol because alcohol, although it makes us drowsy and we think it's putting us to sleep, it actually disrupts our deep wave sleep. And controlling your temperature, the environment, and potentially trying to change negative thoughts that you might have around sleep. And there are medications for sleep, and I think a lot of times that those are useful, but I don't think we should be dependent on them. Melatonin is actually a medication. It is relatively safe. However, there isn't a specific dose that's agreed on. And yes, you can use it and it could be beneficial, but I wouldn't necessarily look at it as something to cure all. I think you need to look at it as a bigger picture.
And then PK asks about naps. Do naps, if you're taking naps in the day, help, with getting enough sleep?
It's kind of unique to the individual, and some people almost seem to be hardwired to be nappers and others are not. So it really depends on the person. But taking a nap late in the day, if you've recognized that it inhibits your ability to fall asleep at night, that is detrimental. Yes, but a brief one here and there, if you find it refreshing, that's probably fine.
Wonderful. All right, so let's move on with our slides.
And so I just want to put out on the table here that our fears of dementia are actually greater than our fears of cancer. And that's contributed to by our living in this hyper-cognitive society where rational thought and coherent memory, along with independence, are core values. So we've invested very heavily in research to find a cure or a treatment. And fortunately, the momentum in research around dementia has finally really gotten to where it should be, close to $3 billion. And we need that amount of investment in research. We are getting closer to finding something which can be a treatment. It's most likely going to be more like a cocktail, not any one pill, which is a magic cure, but a combination of things. And in the meanwhile, I firmly believe that by confronting mortality in our own life and realizing that we may come down with a dementia and planning on that potential outcome enhances our ability to enjoy our life today. Next slide.
That's really important, and I'm glad that we're going to be talking about planning here shortly. Two of our audience members have mentioned that they've had family members with Alzheimer's and that they're both very stressed out about it. It's causing a lot of anxiety in their lives. Can you address that? How to really understand if it's hereditary and just how to calm the anxiety around it?
So there are certain types of dementia which are hereditary. Those are typically the younger onset ones, though, people in their 50s. And for late life dementia, there are multiple things which appear to be contributing factors. Simply having a direct family member who came down with an Alzheimer's does increase your risk by about 30%. So that's the current thinking around that. So for someone who is 65, they've got, say, a 2% chance of coming down with Alzheimer's in the year, or annual risk of coming down with Alzheimer's. And if they have a family member, then they have a 30% increased risk, which takes that 2% and turns it into 2.6. So yes, there is a potential increased risk. However, there was just a recent article that was published stating that if people drank 5 to 6 cups of coffee a day, their risk was increased by 50%. So those risks with family members are relatively small. I think they do the most damage by really increasing our fear.
Good point.
So how about the annual wellness evaluation? In that evaluation, the brain is the only vital organ that is not routinely checked. So we're all grateful for the wellness evaluation. But a survey that was done in 2019 of primary care providers showed that 82% of seniors think it's important to have their thinking and memory checked at an annual examination, and over 90% of their doctors agreed. However, less than half of the doctors actually did it. So I'm afraid we have a big disconnect here. Speaking from the physician's side of this mismatch, I can only share with you that over the decades, what doctors have on their required to-do list has only gotten longer. So I need to ask everybody who's on the other side of this mismatch to drive change and ask for an evaluation. So here's an idea, all right? Something that everybody can do. And I've put together some points here from a cognitive screening test that's actually used in research and in clinical practice. Over the last years, have you noticed a significant change in any of those bulleted items that are on the screen there? Have you seen a significant decline in your problem solving or judgment skills, your engagement in hobbies or activities not related to physical limitations, your ability to keep track of appointments or meetings and using a calendar is okay? Has there been an increase in your repetition of comments or questions that friends or family have notified you about? Are you having more trouble learning how to use a new tool, such as an appliance or an electronic gadget? And are you having more trouble keeping track of the month or the year? Losing track of the date every now and then is okay. So if you've answered yes to more than one of the things on that list, I think that's something you should bring to your doctor's attention. And I think we have that as a tip on our next slide.
Right. And I also want to say that it's really important to have those conversations with your doctor too, because I mean, we make these assumptions. I'm a hypochondriac. I'll just put it out there, right? And I know other people like me as well, who make these assumptions just because there's a change, it must be the worst thing, right? Mm-hmm. And the doctor is the only one who can determine if your thinking is, founded there. So absolutely, don't be scared to go to the doctor.
All right, next slide. Now let's start talking about the normal brain, because I think if you understand the complexities, you'll understand how many ways it can go just a little bit off and still be in the normal range. So here we have a picture representation of the different lobes or regions of the brain. In the front, the large red area, those are the frontal lobes. That's involved with problem solving and behavior, as well as voluntary motor movement. And it's a very large area. I once heard someone who studied the frontal lobes describe them as so important, though. He said, frontal lobes, never leave home without them, because you can get into a lot of trouble with frontal lobe damage. The parietal lobes in the yellow there are important in determining right from left and sensation, body orientation. And then the green area at the back, the occipital lobe, is where visual images make sense to us, where that's all sorted out. And then the large blue area on the side there is the temporal lobes, which is the hub for learning and memory and much of our language. So on the next slide, you actually see a digital representation of all of the connecting systems between those different regions of the brain. The nerve cells or neurons are on the surface of the brain, and they connect with other nerve cells into other regions of the brain through the connecting tracts. And that is a digital representation of those connecting tracts. And as we move on to the next slide, and we'll look at another MRI scan of the brain. So this is an MRI scan picture of the brain, and we're looking at the brain cut like this, right, like that. So the eyeballs would be in front of this, and you can see the lobes of the brain off on the side there. And the normal brain is that sort of medium gray, and the bright white areas of projection are slightly abnormal. And that can happen when you have damage in those tract systems connecting the different regions of the brain. The processes connecting the nerve cells are covered with an insulation called myelin, and it tends to break down. In addition, you can have a mismatch between how much oxygen the tissue wants and how much brain tissue wants and how much it's actually getting delivered. And you can damage those connecting systems going between the different areas of the brain. Also, there is shrinkage of our brain with aging. And the hippocampus, that hub for learning and memory, is one of the areas that shrinks. As a matter of fact, at 65 and older, it shrinks at about a rate of about 1.4% per year. And it goes up to about 4.5% per year if someone has an Alzheimer's disease. On top of that, then the receptors or the receptacles on the next nerve where they connect to each other and move the message along, they may not work as normally as they should, or they may not be as efficient as they should. So I think it's good to understand there's a lot of areas where we can have little bits of damage that slow things down, and that's kind of the new normal. Next slide.
But I want to answer for a couple of people in the audience. Yes, these slides will be available for you. We'll send you a follow-up email with the recording, a link to the recording as well as the slides.
So how do we adapt to these normal kinds of changes in the brain? I think most of us can recognize it is more difficult to multitask. I think I was in my 40s the first time when I was trying to fix my own cereal on the counter while making the dog's kibble bowl, and I put the blueberries on his kibble. It's like, and meanwhile, I was responding to emails and, talking to the kids and trying to get them off to school. You're going to make a mistake. So keep it simple. As we discussed earlier, retrieval of words frequently takes longer. The information's in there, but it takes longer to find it. We both think and move more slowly. So allow yourself more time.
And I also want to say I've made that same mistake of confusing the dog's medicine with my own medicine. I give the dog my allergy medicine, and I took her arthritis medicine. So it can happen to anybody.
All right. And this is a pretty ominous looking slide here, because I'm a big believer in just putting stuff out on the table so we can start the discussion. And this is a good perspective of a dementia. It's an existential crisis. How can we even imagine anything as terrifying and depressing and anxiety provoking as a neurodegenerative illness that's going to silently spread through your brain and steal your thinking, your memory, leaving you unable to care for yourself? That's terrifying. So we need to talk about it. Okay?
Yes, we do need to talk about it. And from somebody who has actually worked in memory care, I know that the conversations that we have with families are so important, and that they wish that they had this information a long time ago.
Absolutely. So for a good conversation starter, I oftentimes recommend this card game called Go Wish. And so Lola and I are going to actually work with this a little bit. Now, the way you play this, Lola, is you take all of your cards, and Lola and I do not have a full deck. We have partial decks. But the way you play this is you sit at the table or wherever you gather with your family, your loved ones. And on the first slide there, or on the prior slide, you could see that there were like different colored decks. So ideally, each person has their own deck and their own color, and you sort through the cards into what is the most important to you, what's kind of middle of the road, and what is least important. So as I'm looking at my cards, I think that I would want to say that not to be short of breath is going to go into my important pile, because as someone who has had severe asthma, I know being short of breath is terrifying. How about you?
So let's see, one of the items here, to be able to talk about what death means. For me, that's very important. I know that it makes people sad to talk about, but I think it's really amazing sharing our ideas of what death means and the idea of legacy, because we do live on after we die. We live on in people's memories and people's hearts. And so that shouldn't be lost. I mean, for me personally, I want my family to think about me often with joy and not sadness.
Yeah, and there are other cards which are in here. This card right here, to have my family with me, I kind of put that in I'm not so sure pile, because I don't know if I want all my family around me. That's not how I envision it.
And this one for me, to have my funeral arrangements made, it's important that I be part of that, because I've actually already started my playlist of the songs that I want played at my funeral. And I want to record a message to the attendees. And I'm going to roast everybody in the room. I'm going to tell all of their secrets. And so I've already planned this. I've pre-planned this, even if I may, it could be 40 years before I go.
So this is an absolutely wonderful conversational starter that I think is non-threatening. And Lola's going to go ahead and send you a little link as to where you can get these cards.
Yes, I'll actually show it here on screen. So the website is gowish.org.
All right. Thank you, Lola. So now I would like to talk about something called prospection. And the reason I'm talking about this is it's really an important consideration when you're planning your future and when you're talking with a loved one about what they want in their future. Prospection is the ability to mentally simulate potential events at a future point in time. So this requires putting out a set of potential outcomes and deciding which one would be best for you. If we go to the next slide, I've got a few more bullet points about prospection there. It's future-oriented thinking. So for example, if I'm thinking about what I'm going to do over the holidays this year, I need to retrieve personal information. What happened last year around the holidays? Who came? What are relationships in time and space? Are there family members who aren't going to be available? How much room do I have? How many serving sets do I have? Considering the risks in different scenarios. I like to spend time planning the seating arrangements to get the best conversation and avoid family squabbles, because of course I host everybody at my place. This ability is markedly impaired in dementia syndromes. So for the many years when I've been seeing patients and I'll say to them, well, what are you going to do when you need help? You need to plan for that. And they would say to me, well, I'll take care of that when I need it. And for family members that may get frustrated with that, I'd like everybody to recognize that the person with impairment might actually be giving that kind of an answer because they are not capable of doing this type of forward thinking or prospection. And on the next slide is another new word, anosognosia, which is lack of insight. It's not denial. And so anosognosia is present in a great number of people with cognitive impairment. On the next slide, we go into that a little bit more. And I want everybody to understand that it's coming from actual structural changes in the brain that facilitate referential thinking. So it isn't, again, that this person doesn't want to talk about it. They may not be able to do it. And so this can prove to be a significant obstacle to evaluation and future planning. It's severe in about a third of patients with Alzheimer's, and it's present to a variable amount in many of the others. And the risk for suffering from this anosognosia is increased with lower educational levels and individuals with more behavioral symptoms. So this is a very, very important concept to understand, that the person isn't necessarily in denial. They honestly cannot see what is going on.
So when it comes to the changes of you don't recognize a certain person like a daughter and you start calling them by their your sister's name, for example, does that fall in one of these two categories, prospection or
No, it
no?
actually doesn't, because that relates to the memory of that specific person or individual. So that's not quite the same. Although it's, I mean, I could probably come up with an example around a daughter, but that's not exactly the same as not recognizing a family member when you see them. So what are the potential benefits of cognitive screening? I've seen a good number of individuals who actually found it a relief when they can see that they are doing okay. It can relieve anxiety. In addition, with screening, and actually what I'm referring to here is pretty intense neuropsychological testing, which isn't always done by Dr. Lowley. You'd mentioned that earlier. That's usually done by neuropsychologists. But to get really good cognitive screening, I think getting full neuropsychological testing is a good investment of time. It can identify areas of strength and weakness, and you can figure out how to use areas of strength to work around areas of relative weakness. And this can help initiate discussions about the future, that prospective planning that is so very important. It can also help us with getting started conversations around advanced directives or the physician's orders for life-sustaining treatment, the POLST form, which puts limits on CPR. And by maximizing our independence with these sorts of forms, we can maintain some sense of control.
So we have somebody who's asking, where's a good place to get cognitive screening?
Well, so I'm talking about screening, I'm talking about neuropsychological testing, and you're right. I kind of mixed those together because I didn't put separate slides up. Cognitive screening oftentimes can be done by your doctor. There are different screening tools that a doctor can use, and that can be your primary care doctor. You can ask to go to a specialist, though, to go to a neurologist or a geriatrician. And the neuropsychological testing, a doctor typically needs to refer you to that because that's done by neuropsychologists. And you can find neuropsychologists, but really your doctor's got to know of some neuropsychologists because you need the order from the doctor so that your insurance will pay for it.
And is some of the screening, would they be called like the MoCA test or drawing the clock face?
Yes, absolutely. The Montreal Cognitive Assessment, which includes a clock face on it. There are some abbreviated screening tests using just a clock face and a 3-word recall. There's something called the SLUMS, the St. Louis University Memory Screen. There's a lot of different screening tests out there that doctors can use.
And then as Shirley asked, does delay in diagnosis lead to more severe disease?
Possibly. I have more concerns that a delay in diagnosis honestly leads to more suffering, because I think getting education and support early in the course of an illness lessens suffering. And I could think of an example there. We talked about sleep. I didn't really mention sleep apnea. So an undiagnosed and untreated sleep apnea can cause sleepiness during the day. And if that's undiagnosed and untreated, it actually increases your risk for coming down with the dementia later in life. So if someone's fuzzy and they're not getting an evaluation, yes, it could lead to more faster disease.
So what about for people who are living alone and they're in their 80s and their family is not very supportive? It sounds like this person is a little nervous about getting any kind of diagnosis. So maybe either they don't have somebody to help them or their family just doesn't want to necessarily be involved.
Well, then getting someone who is a close friend to help you Or there are also groups like Seniors at Home with JFCS, where you can get care consultants. And if you are alone and family isn't involved and you can afford to get a care consultant, I think it is an excellent investment, because then you will have someone you feel you can trust who's working on your team.
Right. So care consultants are also, you might Google geriatric care managers.
Right.
Most of the time they're private pay, but if you're part of a Kaiser or a system like that, you may have access to one through your insurance group. All right, so we have another poll, and this is going to be about advanced directives. So let me cue that one up. And poll number 3. Here we go. Can you see that? Question number 1, do you have an advanced directive? Question number 2, do you know where it's at? And question number 3, does your advanced directive detail choices pertaining to care if cognitively impaired? So while everybody's filling this out, I went through this process with my mother last year, and we are with Kaiser, and we filled out the advanced directive and turned it in. She was very open to talking through the questions, and I was surprised by it. So she answered the questions, I wrote them down for her, and then we turned that into Kaiser. I also recently went through one doing a trust, and I used LegalZoom to put together my trust, but the advanced directive was in there, and it was called the living will. So I noticed that they have different names depending on who's putting the document together. So let's go ahead and take a look at what our audience is saying here. We're only about 65% of you have filled this out so far. So I'll give you another minute or a moment or two. And Dr. Madison, do you have an advanced directive?
I do have an advanced directive, and gosh, Lola, I'm going to have to confess, I haven't filled it out as well as I would like to. So we have a link, or Lola can send you a link to the one that I have filled out that I do like, which is called Prepare for Your Care. And that came out of a geriatrician based with UCSF, and it's state specific. So I think Lola's going to send you a link for the California one. And the reason I like that advanced directive is because it's got a sliding scale on it about what's important to you, length of life or quality of life.
Mm-hmm. Mm-hmm. And Dr. Madison, do you know where your advanced directive is right this moment?
Yes, I do.
Okay. Mine is in my briefcase, because I don't know where to put it. I have a safe, but doesn't seem like that would be the right place to put an advanced directive. So let's see what the audience is saying. Out of the people who've answered, 89% have an advanced directive. That's amazing.
That's great.
Wow, I am so impressed. I'm so proud of you who have
one. And 87% know where it is. That's fabulous. I'm sorry, but this is a much better connected audience than I'm used to working with.
Yes, yes. And then does your advanced directive detail choosing choices pertaining to care if cognitively impaired? 52% said yes. Now, is this, I can't even remember if this is on my advanced directive that I filled out. So I'd have to go through and look at it. But is this something that's standard on an advanced directive?
Let's go to the slides, because I have the actual language from a typical advanced directive, which is in a will or a trust.
All right, let's take a look at that.
And as I have on the slide there, when I talk to people about it, I usually get the answer, oh, we've done that. And then I ask where it is and they have no idea. That's been my experience. So the typical advanced directive pertains to a certain type of a situation here. And that is if we are in an irreversible coma or a persistent vegetative state, if we're terminally ill and connected to machines for maintaining life that are merely delaying the moment of death, or when it appears clear that under any other circumstances, the burdens of treatment outweigh the expected benefits. And so if you have a major car accident and you're in a coma for a month or something, extreme like that, this can be a fairly clear sort of a yes or no option for family members. But neurodegenerative illnesses or dementia spread through the brain over years to decades. And so this kind of a clear decision point about end of life is not frequently an option. And so the typical language does not include sharing your thoughts in the condition of a dementia, what you would want or not want.
Sense. So we've got some questions streaming in, and so I thought this would be a good time for us to ask a few or answer a few questions. Let me go to here. Let's see here. Oh, and actually one person said their doctor asked for the advance directive and has a copy of theirs, so that's fantastic.
It is good. Yeah.
Yeah. Aurora asked a question, what part does hearing loss play?
So hearing loss can actually contribute to your risk for dementia. This doesn't necessarily relate to advanced directives, but hearing loss is a risk factor for dementia. So if you do have hearing loss, you should get evaluated and get hearing aids, because some of those connection systems from the ear into the brain, if you leave them idle long enough where you're not hearing, they won't actually regrow once you get a hearing aid. So hearing is very important.
And we've got some questions around medication. So galantamine, I know I didn't pronounce that right, to delay onset, is that, what's your opinion on that?
I'm sorry, I didn't understand what it was.
What is your opinion of galantamine to delay onset?
So galantamine is one of the
Galantamine,
medications used to treat Alzheimer's. So it's not delaying any onset, but it's one of a group of acetylcholinesterase inhibitors. Donepezil and rivastigmine are the other two main ones. There's three of them. And I do believe that those medicines are beneficial. They don't work for everybody, and yes, they have side effects, but I always let patients try one of those medicines. Probably a good half of patients perceive benefit from it. And I mean, it's nothing miraculous. It's not like you're going to go on and win Jeopardy. However, there's frequently less repetition of questions, and I've had patients say to me they feel their brain is better connected. The benefit, however, does not necessarily stay, and it appears that the benefit starts to wane after a year and a half or so. But again, this all depends on the individual. Everybody's unique.
And then we have Sam asked about the new drug that was approved for Alzheimer's and what your opinion is on that one.
Obviously that's a very loaded question. I mean, there have been resignations and multiple editorials and presentations around that. And I think it was absolutely wonderful that it was quote unquote fast tracked. All right, putting Alzheimer's up there in the category of illnesses that we really do need to expedite their approval if it looks like there's something good. Whether or not this one should have been the one that was fast-tracked first, I think is what's really up for debate. And so I think there is potentially a group of people that can really benefit from this medication, but we have to really be careful and identify that group and target them with the treatment, because it has potentially significant side effects as well.
And I know there was a couple other, there's a few questions in here or comments about different outside of the box treatments. I saw somebody asking about they said John Hopkins has been doing research on psilocybin mushrooms and dementia with good results. Do you have any information about that, Dr. Madison?
I don't have the most current information on what Johns Hopkins is doing about psilocybin, but it's one of the many out-of-the-box approaches in dementia research that I think are going to get us some answers or treatments sooner.
Mhm. And have you heard of any other different types of treatments that you want to share with the audience today?
There's a lot of different types of treatment approaches that are being explored. Several of them are looking at inflammation. There was an association between gum disease and dementia. So they're looking at certain bacteria in the mouth and inhibiting an enzyme released by that bacteria. There are other things which are looking at some of the other abnormal proteins that accumulate and targeting them with antibodies or modifying proteins in the production of tau, which is one of the, which gets clumped with this phosphorus inside the cells. And so they're looking at a lot of the chemical pathways in there and seeing if those can be influenced by the treatments. There's gamma radiation, there's light, there's all sorts of treatments out there. And there's also a lot of research going into lifestyle intervention. And that's what we're going to hear about in the second talk with Dr. Ornish.
Yes, and I'll bring that up before the end of the presentation today, is that we have our next brain health webinar coming up on November 4th. We actually have a series of 3, and the third will be on November 18th. Now, how do we go through some of these articles that we read in the news that are things like, oh, stop taking Benadryl. Benadryl has been seen as having a potential impact on memory and dementia. And it's just that there's something new every day. I mean, somebody here said they thought coffee was supposed to be good, not bad. How do we weed through all of these messages we're getting in the media and find out what's best for us?
That's a huge question because you're being bombarded. We're all being bombarded with information. And I'm afraid for someone like me, I can just kind of sift through it quickly. But if you don't have the medical background to do that, it can be completely overwhelming. I think if it's something which keeps resonating in the media, bring it up to your doctor and talk with your doctor about it. I always advise against the use of Benadryl.
Thank you. So did my doctor. So, but I noticed it helped me sleep better and have better dreams, but I stopped using it. Now, Lorna asks, other than B12, what other supplements could be used for preventative?
That's another huge area for discussion. And there are quite a number of supplements that are put out there commercially and advertised as something that will prevent dementia, but you have to realize that all of those over-the-counter supplements are making claims that are simply marketing. None of them have been approved by the Food and Drug Administration, like the medication. So they can make a lot of claims, just and sell people by their marketing. So I'm not a big fan of supplements, although I will share. Of course, I take the calcium and the D and a little bit of vitamin E and some zinc and a multivite. Yeah, I mean, I take some too. Again, it's finding the right combination for you. Oh yeah, and I take a B12 as well because my B12 was okay and I wanted it higher.
And I take B12 because I notice I'm in a better mood when I take my B12.
And that proves my point. Everybody is unique.
Yes, exactly. So can 2 cups of coffee a day be harmful? You mentioned earlier that there's been.
Yeah, they shouldn't be. They really shouldn't be, because there are others. Again, I think you mentioned, Lola, someone put in there, yeah, but coffee's supposed to be good for us. You're right. Coffee can help with memory. So it's always finding a balance there. And so 2 cups of coffee can be absolutely fine. Yes.
Right. And I mean, it's in moderation, right? Just like we see articles out there about how red wine or dark chocolate could be good for you, good for your heart. All of that in moderation, and always check with your doctor and what works best for you. Carol asked, did she hear us say that you recommend against Benadryl?
That is correct.
That is correct. Yes.
Diphenhydramine.
Right.
Let's use the chemical name for it.
Right. And I also want to share that one person in the audience says that he's managed dyslexia his entire life and has MS and is still biking. And, being active and finding the things in life that you enjoy. And our third presentation that's going to be on November 18th is about our mindset, right? And
Yeah.
how if we have the positive outlook, that it doesn't really matter what we're challenged with, we can rise up and still enjoy life.
Absolutely.
And do you have any recommendations about that, about overcoming challenges? I mean, we all have challenges in our life that we have to overcome. So is dementia just another challenge?
I tell people it isn't something which is a life ender, but it's a life changer. And if you can look at it as another challenge and work around obstacles, you're going to do much better with it.
Now, we did allocate until 3:30 for today's presentation. I'm going to go ahead and share our slides. We only have a couple of slides left, and then we can turn back to audience questions.
Okay.
There we go.
I think you skipped a few. No?
No, we were just,
okay.
Let's see, we were just on advanced directives.
Okay, there we go.
Yeah.
All right. So for a few closing points, I'm hoping everybody is taken away from this that there are changes in brain function with aging that are normal. And as we have mentioned, a healthy lifestyle can influence our life's trajectory. And that cognitive impairment or a dementia is diagnosed in the United States every 66 seconds. I actually hadn't given you that little fact previously, but it ties in with how prevalent it is. And that individuals with cognitive impairment frequently do not see their deficits. They are not necessarily in denial. That confronting the mortality of life and planning for the future can reduce our fears and enhance our joys today.
So with that, let's go ahead and type your questions in the chat box. I see a couple of people have been using Q&A as well. And let's get a few people that we haven't answered their questions yet. And I also, while we're waiting for people to type their questions, I want to talk a little bit about the word use of impairment versus cognitive change. Because as we're learning through this, there's normal changes in the brain. Our cognition has a normal change to it. And when we use the word impairment, it's kind of like the word frailty or elderly. It has a negative connotation. So what are your thoughts, Dr. Madison, around that word use and how that and our reaction to it?
Well, there are two things here, though. There are normal changes. And so we work around those normal changes. But when changes are beyond normal, that is the definition of an impairment. And so I do think we need to use the term because it isn't normal. And while I'm saying we need to use the term, by no means does that mean that I feel we need somebody who has a cognitive impairment or a dementia, that we don't have to make them understand that they have impairment. That's not necessary at all, and it can actually lead to distress because of what I was discussing earlier about anosognosia. They can't see it. So if you try and convince them that they have impairment, you're only going to get into an argument and the situation is going to get worse. You can discuss with someone who has impairment. You can label it as cognitive change, understanding that they cannot see that it's impairment. But for me, from the doctor's side, and for anyone who is acting as an advocate or as a care partner, I think they do need to understand if it's impairment.
Gotcha. And also, I've noticed that there's a lot of, like, when we're talking about denial, or trying to force somebody to see it your way, there's a lot of change being made within the medical industry that is not, no longer trying to force reality on somebody, to allow it to take its own course. And for example, if somebody is being loaded into an ambulance, and the EMT person knows that this person has a dementia or an Alzheimer's, they're going to treat them a little bit different, as far as, saying, being kinder and not trying to force them to understand that today is Tuesday, and we are going to the hospital and this is happening. Have you had any interaction with professionals who are getting this extra training for their day-to-day jobs, so that they know how to better communicate with people with dementia?
I haven't had personal interactions with that movement, but there's a large movement, particularly around educating emergency room staff to those kinds of changes in patients, and making emergency rooms more senior friendly, and at the same time more friendly to individuals with a dementia or a cognitive impairment, because it can be a huge problem. You're right.
Yeah. And even with police officers, understanding mental health better, understanding that people are living with dementia, and that they need to be treated with a special touch.
And sometimes I think an ID bracelet can be really good. And I've seen people do an ID bracelet that just said, my name is so-and-so, I have memory problems, please contact so-and-so. And having that on a bracelet can be valuable.
So Paula asks, are negative behavioral changes normal, such as paranoia?
No, they're not. They're really not. And so paranoia is a distinct fear, a fixed fear about something. And unfortunately, it happens frequently in dementias. Over the course of a dementia, probably 80% of people will go through at least some period where they experience a paranoia. And it's then hard for family members or care partners to work around it. But there are certain ways of trying to communicate with individuals that can help you work around it. I just recently did a webinar with Allison Kuhn, who wrote a book with Dr. Jamie Hopkins called I Hear You. That's all about trying to communicate around these impairments, including paranoia.
And what was the name of that book? I Hear You?
I Hear You.
And who wrote that?
Dr. Jane Mahakian and Allison Kuhn. I can send you the link later, Lola.
All right, Allison, I'm typing it in here. I did not spell Mahakian correct, but for all of our attendees here, I wanted to make sure that they have it, and I will include it in the follow-up email as well. Are delusions associated with the diagnosis of Alzheimer's?
They can be. They can be associated with any of the dimensions. So delusion is a false, fixed belief. And so you can't convince the person of otherwise, or tell them that they're wrong, and convince them that you're right. You need to figure out a way to work around it. I've actually sometimes said to families, well, she thinks that her father and her brother are coming to dinner with her. And I said, great, pull up a chair and set a place setting. As long as they're not causing trouble, leave them be.
Mm-hmm. That's great advice. All right. So life stresses, can they increase the dementia to happen faster?
They can actually increase your risk for dementia by disrupting sleep. And there have been several studies showing the benefits of meditation on regrowth in the hippocampal region of the brain. The hippocampus is the main part of the temporal lobe that's essential for learning and memory. For people who have a dementia, I don't know that there have been any studies showing that stress makes it go faster. but it's certainly not good for them.
Mhm. And the stress can be felt from their family members too. So it's not just their own stress, it's
Family
what's around
members
them.
family members who are under stress are causing harm to themselves. And a family member who is more comfortable with themselves and not stressed is going to actually be providing better care.
And there's a research study that was done that family members who are experiencing high stress have a higher potential of passing away before their loved one with dementia does from heart related conditions and stress related conditions. So it's definitely, if you are a family member caring for someone with dementia, please take care of yourself.
Which is easier said than done. You need good strategies and support.
Exactly. We could do a whole series of webinars just on that. Okay, so there's a couple more questions about medications. So one person was asking about statins, and if there's a relationship between statins and dementia.
So there was one physician who had published some research around statins and memory loss or dementia, but that was later, that was not supported by anyone else. And certainly the benefit for someone who's taking a statin, the benefit in terms of the reduced risk for cerebrovascular damage, small strokes, which can cause dementia in and of themselves or contribute to cognitive losses, is well worth taking the statin.
And a couple people were asking about the length of time it's taking them to get the cognitive screening, the testing that they're looking for. And my personal experience with my mother last year was because of COVID and her not being able to go into the memory care center at Kaiser. She wasn't getting the testing she needed in a timely manner. But I've also heard that people, it could take them quite a few years of going back to the doctor and really being a patient, having a patient advocate or being their own patient advocate to get an accurate diagnosis. What are your experiences around that, Dr. Madison, as far as people trying to get help and not having access to the right medical center or doctor to do that screening?
So my experience with that, there was kind of two questions that were asked there. And one of them has to do with getting in to see a provider where you're going to somebody, and it sounds to me like they're not listening to you, because when someone was saying that it's taking years of asking to get an answer, that's unacceptable. I think that's completely unacceptable. And I tell people, you need to go see somebody else. The other issue is that it can take 3 or 4 months sometimes to get in to see the specialist or the doctor. And unfortunately, that's just kind of the way our medical system is, the way it's set up, and the increasing demand, the increasing needs.
And making sure that you're getting to the right type of doctor, because if you are experiencing certain things that are like mental health episodes, you end up with a psychologist or psychiatrist, and you may need a neurologist in this case. And so having to maneuver through those different doctors and asking the right questions can be tough.
It is tough. Yes.
Yeah. Right, so let's see here, other questions that are coming in. We've got so many great questions here, and I know we're not going to be able to get to every single one of them. So what I will do is I will make sure that they are answered in the follow-up emails that we're sending out. Let's answer Joy's question. Can you provide more information on advanced directive languages related to dementia? So there was a couple questions in here about advanced directives when it comes to dementia, because no diagnosis is listed in the advanced directives. So how do you fill one out if you specifically know you have dementia or you anticipate it?
So there are several different ways that you can approach that. I mentioned the prepare for your care which actually does have a whole series of choices similar to the polls that you were using today, Lola. There's a series of choices asking you if it would be acceptable to you to be living under these conditions. And they put out conditions like being unable to take care of yourself, unable to communicate with family members. So using that Prepare for Your Care advanced directive, and for anyone who's done an advanced directive, you can update your advanced directive and do that at any time. I mean, you do need to get it, witnessed or notarized, but it can be redone and you can be more specific with it. In addition, what I like is Dr. Katie Butler wrote a book called The Art of Dying Well, and she has in there a whole sheet of things that you can check off that you do not want. I actually feel that her sheet is overly specific. It's a full single space type page. I like to take like maybe half of what she's got on her list there, and you put it as a letter to your family. And put a letter to family saying that, if you were reading this, then I'm assuming I am no longer able to make decisions for myself, and I do not want this, and stating clearly if you don't want something like a feeding tube, if you want only comfort care, so you need to write out as much as you possibly can. And then you need to share it with your loved ones. My husband and I chose, we have 3 daughters, and we chose the one who we felt would be the most capable of pulling a plug. And she agrees with us on that. So, you need to be careful who you are going to make your agent and make sure that they understand what your priorities are. I've said it only took me about 20 years with my husband to convince him that I never want him to keep me as a potted plant.
I have all sorts of stories I could tell around that. But yeah, those are conversations that for some people are tough to have, and for others they make light of it. But I like what you're saying, Dr. Madison, about writing out a letter, and especially using the Go Wish cards as kind of a foundation of that. Because if you're able to have the conversation, document it, right? And so that way people do remember, because years passed, and sometimes we make decisions for our loved ones that they wouldn't make for themselves, and we want to respect what their wishes are. All right. So let's see here. Let me read this to you. I have a loved one who is exhibiting some of the symptoms Dr. Madison outlined earlier, like limited insight, difficulty making decisions, forgetfulness, and decreased interest in hobbies. However, she is refusing to go to the doctor. Do you have any suggestions for what to do in this situation?
I do. So what I have sometimes done is I will see patient pairs. And so particularly if it's a spouse, say that you're concerned about yourself and you want your, the other better half to come with you and go through it together. So you have to have a doctor who's willing to do this, but try and approach it as a team. And, for many of us, it's legitimate. Boy, I have concerns too. Right. So that's one way to do it, because it's really hard to spring something like this on someone. And if you've got someone who doesn't have any insight, and you are able to manage to arrange a visit and you've gotten them to agree to it, don't remind them of it and don't tell them about it the day before. Just, when it's maybe that morning or, just before you go, oh, remember we said we were going to do this. Come on, let's get your coat. We're going.
Mm-hmm. And sometimes it hurts. It's a sting, and it hurts for a little while. When my mom had to move into a adult care home, and I made her make the decision throughout the whole process. She decided, but then when it came to the day, I knew she was going to try to backpedal, and we basically said, we're taking you over there. Let's enjoy a meal together. This is the place that you selected. But when we got there, her stuff was already moved in. Now, I don't know that that's the right way to do it, but that was, that's the way that families have to sometimes take the lead to get things to happen for those who can't necessarily make the decisions on their own.
And I have another strategy for that as well. You come up with something, some people call it the kind, in quotes, kind of a lie, in that you'll say something, we call it therapeutic storytelling. Mom, you know what? All of the windows on your apartment need to be replaced. The group is coming in and they're leaking so badly, and with all the, the cold air coming through, everything's got to be replaced. So I'm afraid you've simply got to get out of your condominium. And we don't have a clear timeline how long it's going to be. It could be several weeks. And so we found this other place for you to hang out where it's nice and cozy and comfortable while that work gets done. And that work just never gets finished. Or, when they were replacing the windows, oh my God, they found out the plumbing needs to be done.
And this happens a lot when people move into assisted living. We hear this from families so often, is that the loved one who's living in assisted living thinks they're going to go home someday. They think that they're going to get better.
And that's fine. Let them think that. Leave them with that. That's fine.
Yeah. All right, let's see here. We got so many great questions answered. We have just a couple of minutes left. If you have a question that you're just really needing an answer to, please type it in here. I have one here. I'll read. I am 76 and noticed my memory declined some 20 years ago, but have worked hard to maintain my cognitive abilities. Probably no worse today than where I was then. However, my decline is selective. I have a heck of a time remembering new people's faces and names, no matter what tips I use. What do you say to this? Any specific tip you might be able to convey?
From the way that question is worded, I've got a hunch that this person is already using any of the tips that I might be able to add to that, like repeating it, because when you hear it, you learn it better, putting it in context, making a story. So there's a lot of different tips and techniques. But this is when you're meeting someone new, I oftentimes explain that as you filed so many names and faces away already over the years, and you just keep adding more and more and more and more. Going back to those slides we were looking at in terms of the brain connections and all of those fiber tracts connecting them, you can run into problems retrieving that information.
Right. And it does sound like this person has a positive attitude about it, because they are actively working at it. Right. And there's a difference between that and then just letting things slide. We've had some questions that have come by about the relationship with physical activity and memory loss or cognitive decline. And, these are all things that we know are good for us, right? Exercise and is there a relationship there, Dr. Madison, between exercise or physical activity and memory loss?
We're trying to better understand the exact relationship. Is it the blood flow? Is it the oxygen? Is it growth factors? There are a lot of different things which could be contributing. So we are trying to better understand the scientific relationship, but we do know for a fact that regular physical exercise is beneficial for brain health. And I describe it as probably the most important of those pillars that we use for maintaining brain health.
And then there's a couple of questions around what sleep aids should somebody use to get a better night's sleep. We talked a little bit about melatonin and the fact that benadryl is not recommended. So one person asked, why is benadryl not recommended? And another says, well, what should I take?
Again, it's kind of hard to answer in this sort of a format. The benadryl has a long, or diphenhydramine has a fairly long half-life. It hangs around and it causes cognitive clouding. That's why you shouldn't take the benadryl. And as I mentioned earlier, there are some medications specifically for mood, older medications like trazodone, which can be beneficial for sleep, and using those on a short-term basis is okay. Supplements, we talked about the melatonin. I recommend magnesium. Magnesium can actually help with sleep. It certainly treats muscle cramps. And so magnesium can be beneficial at bedtime. But if somebody's really stuck, again, they need to look at sleep hygiene, and they need to possibly look into what's cognitive behavioral therapy for insomnia. If you can't fall asleep, you need to look at how to really change your thinking patterns around sleep.
Great. And then the last question that we'll have you answer is, how do you find out about clinical trials?
Clinicaltrials.gov, or if there's a trial match service through the Alzheimer's Association. So if you go to the Alzheimer's Association and then search for trials, that should get you to their trials page.
So I'm typing that in for everybody, clinicaltrials.gov. And then the second one was the Alzheimer's Association website.
Trial match.
Trial
match with the Alzheimer's Association. You can also just look at the major universities near you. On their websites, they will list clinical trials and usually a call number.
Wonderful. Thank you for that. So I am going to share the remainder of our slides here that has your contact information. And let me get that up here. There we go. So we have your email here in the company you're with, Seniors at Home. And then again, this recording and PowerPoint presentation will be sent out to everyone. We also have this information about Seniors at Home. So it looks like there's a lot of services that are offered through your organization. And more can be found at the URL, the website that's listed at the bottom of this page. And the recording will be emailed to you early next week. I should have it out to you probably on Monday or Tuesday. Again, thank you to Sequoia Living and Senior Services of Northern California. Senior Services of Northern California is the philanthropic foundation for Sequoia Living that helps raise money towards some of the wonderful programs and services they offer throughout the Bay Area. And lastly, the next webinar is on November 4th at 3 p.m. with Dr. Dean Ornish, who is the founder of Preventative Medicine Research Institute and known as the father of lifestyle medicine. And he's pretty well known, an author, and this is going to be a really interesting presentation that I'm looking forward to about actually reversing some damage that we may have done over the years through excessive lifestyle activities.
He's actually doing a clinical trial with that lifestyle intervention.
Well, good to know. So if you are not already registered for the next webinar, you will get an email with a link to register. And this is the website here, sequoialiving.org/webinars is where you can find all of our webinars. And to find more information or to donate to Senior Services of Northern California, the web address is seniorservicesnorcal.org. And thank you everyone for attending, and especially thank you, Dr. Madison, for all of your knowledge that you've shared with us. These are things that we need to know about, and that, I hope more people take the time to learn about them.
Thank you, Lola. Thank you everyone for joining us.